hindi na po na-update ang aking safety. Kaya meron mga hindi totoo, may totoo. Okay, thank you. But anyway, I'd like to take this opportunity to thank, of course, Dr. Rivera, the chair of the scientific committee, and also, of course, Dr. Peralta. I had fun memories of working with Dr. Peralta. Masaya. And she gave me the great boost until the end when I did my training in UST. And so this morning, and also of course, I'm happy to see familiar faces. Dr. Flores, Dr. Boson, and everybody. Yung pinanggalingan mo, yun yung bahay mo, di ba? This is still my home. Okay. So, this morning, alam ba ninyo? Hi, honey. And Bernadette, gumaganda ka. Kailan kita huling nakita? Ang tagal-tagal na. Okay, pero big time na. Okay, do you know, alam ba ninyo, that obstructive sleep apnea can kill you? Or much worse, it can kill you softly and silently. Okay, let's proceed. Okay. Of course, I would like to, acknowledge St. Luke's Medical Center after having had my pulmonology training and also bronchoscopy training abroad. So before I proceeded to sleep medicine, my mentor asked me to go back to the Philippines first and to see whether I can practice the discipline. And it's good that St. Luke's Medical Center at that time in the year 2000 already has established sleep center and sleep laboratory. So I'm also quite thankful that they accommodated me and they gave me the biggest break to practice my expertise. Just to show you, this is where I practice. This is a comprehensive sleep disorder center in St. Luke's, and this is an example of a sleep lab bedroom. So it doesn't look like a hospital bed, hospital room. Okay. So my task this morning is to enlighten you on what obstructive sleep apnea can do to you and to your children. So medyo morbid kasi meron akong title na kill. Okay. So I'd like to go first on the definition of obstructive sleep apnea in children. So it's a disordered breathing characterized by prolonged, partial, and or intermittent complete upper air obstruction that disrupts normal ventilation and normal sleep patterns. So it can derange your oxygenation as well as your ventilation, your carbon dioxide levels. And as the American Thoracic Society defines, this is characterized by habitual snoring. When I say habitual, they usually snores 3 nights or more per week or during the week. And also associated again with sleep difficulties and or daytime neurobehavioral problems. Pediatric OSA is not, you have to remember this, is not only a common health problem, but also can result in significant morbidity in the pediatric population and in the adult population. It's good in the sleep center of St. Luke's, I am able to see pediatric as well as adult patients who have obstructive sleep apnea. And going back to the pediatric prevalence of OSA, it ranges from 1 to 5% the general population, and the peak prevalence usually occurs between 2 and 8 years. So it's understandably that this can occur because this is the time that your lymphoid tissues do become bigger, your tonsils and adenoids. And in literature and also in our experience, after the 2 to 6 age range, usually there's a second peak, and that's in the adolescence, wherein obesity becomes a great contributing factor. Pathophysiology of obstructive sleep apnea. Do you know that 2/3 of the causation of obstructive sleep apnea is caused by the brain? The brain is responsible for holding your upper airway open in the face of upper airway obstruction. And 1/3 is accounted for by anatomic alterations. And it's very important to note that collapsibility is very important in the causation of obstructive sleep apnea. And one very common, as I mentioned earlier, is obesity, which can cause increased collapsibility of your upper airway. And also some other anatomic alterations. You have skeletal morphology, abnormality, your decreased velopharyngeal area, increased pharyngeal soft tissue, tonsillar hypertrophy, adenoid hypertrophy, and again, obesity. So there's a long list of clinical manifestations, but most of the time, patients are brought to you only because of snoring. And sometimes parents would tell you that they usually have some pauses, and sometimes it's followed by snorting. Okay? So that's a common complaint. But there are certain situations, especially among adults, that the patient himself doesn't know that he has a problem. And it's the bed partner, who brings the patient to the clinic. So kaya nga sabihin natin, it can be it can kill you softly and silently. So you have here the long list of nighttime symptoms and daytime symptoms. And most of the time, you need to ask leading questions to elicit some of these manifestations. Still, overnight polysomnography is still considered as a gold standard. So we say poly because you're measuring a lot of physiologic signals from the body, from head to toe. No? So it can give you, nothing can beat this, even the best questionnaires in the world. So still, PSD or the sleep study is the gold standard. I have to emphasize. It gives you, it tells you the quality of the sleep of an individual. It confirms the diagnosis. It gives you it tells you how severe it is, the levels of your oxygen, carbon dioxide, arousals. And one thing that also I have to emphasize is that obstructive sleep apnea is never considered normal in children. So you can see here in normative data that it's only less than 1 per hour of obstructive apnea, which is permissible in children. So when you choose to treat a patient, you need to assure yourself that that treatment will give you 100% treatment. So this is just an example of a tracing wherein you have, this is what we usually see when you do a sleep study. So I just have to orient you. This one is your airflow, your thoracic and abdominal movements, the efforts, saturation. And you can see here, you have normal inhalation, exhalation, and then here, the flow ceases. And that's the time that your airway obstructs completely. And down here, you can see that the thoracic movement, the patient develops paradox. And of course, probably you know why they do develop paradox. And at the end of the obstruction, before it is terminated, the oxygen reaches a nadir. So that's when the patient desaturates. So this is me. I don't know if it's going to work, but okay, I thought, let's see. Wait, it's working slowly. There. So that's a diagram. How do I say it? So yes, that's it. So that's how patient with obstructive apnea looks like when they obstruct and when they arouse. Okay. So this is everybody. I don't need to explain this. So you can see the throat is very crowded. You have big tonsils, and this is almost grade kissing in grade 4, and you have what? Marked hyperemia, and this is due to constant traumatization of the soft tissue during the night when the patient snores. And when you see this, of course, you have to start questioning, does this patient snore? Look here. It says here that obesity has become one of the most significant risk factors for OSA in children, and quite interesting, each 1 kilogram per meter square body mass index increment more than the 50th centile is associated with an increased risk of OSA by 12%. Actually, this child is, one of my first few patients, and this patient also, aside from having a sleep apnea, he had obstructive, basically hypoventilation syndrome. And then in front of me, he turned blue when he suddenly slept. And so, because the mother is quite, used to the situation, he just tried to wake the patient. She just woke up the patient, awakened the patient, and the patient regains his normal color. So Cruzon, probably you've seen this. So what I'd like to point out here in the arrow is that they have a very small maxillary bone, and you have a very crowded face. Achondroplastic, mga unano. Kaya pag may nakasalubong unano, pwede mong tanungin, naghihilig ka ba? in city, we have a lot of patients who are on CPAP, achondroplastic dwarfs. And even though you subject them to adenotonsillectomy after treatment, they can still have residual obstructive sleep apnea, and usually they end up using CPAP. Whereas Yereban, everybody knows this, especially those working in the nursery, PERTS, Beck-Witherman syndrome, because of very big tongue, of course, that can it's a space-occupying lesion, kumbaga. And Down syndrome. Down syndrome has an inherent small airway, and they have hypotonia. That's why there's a high prevalence of obstructive sleep apnea in this population. Hurler, because of the deposits, and you look at the neck. If you look at your seatmates, kung titignan yung mga leg nila kung maliliit, ibig sabihin na maikli. So ibig sabihin, baka mataas ang resistance ng airway resistance ng katabi ninyo. Tinignan ba nyo? And Treacher Collins syndrome. Actually, my very first patient, a syndromic patient, is a Treacher Collins syndrome. He's already 16 years old and he's on CPAP. And quite interesting na siya lang ang may Treacher Collins syndrome, pero tatlo sila naka-CPAP at home, the mother, the father, apat pala, and that includes the grandfather. Okay, now, let's see. From obstructive sleep apnea in childhood to cardiovascular disease, and this is an adulthood.